Thank you.
Right. Good afternoon. On behalf of the Northern New England Clinical and Translational Research Network and the University of Vermont Cancer Center, I'd like to welcome speakers and our audience to this presentation. And so, is this on my screen? It is not. And so today we have 4 speakers with us today to discuss health and healthcare in rural Northern New England, challenges and opportunities. And so we'll hear from John Olson, who's Chief of the State Office of Rural Health and Primary Care in the Vermont Department of Health, from Alisa Druzba, who's the Administrator of Rural Health and Primary Care Section of the New Hampshire Division of Public Health Service, from Nicole Breton, the Director of Rural Health and Primary Care Program in the Maine Center for Disease Control and Prevention, and from Anne-Marie Day, the Executive Director of the New England Rural Health Association. Just a couple of administrative items. We'll hold questions to the end. Please feel free to put your questions in the chat box, and Kirsten, Tracy, and I will help moderate the Q&A at the end of the presentation. Thank you so much for joining us. Take it away, John.
Great. Thank you, Jessica and Dr. Stein. Good afternoon, everyone. My name is John. Thank you for joining us today to learn more about rural health in Northern New England. Thank you, Dr. Stein and Jennifer and Jessica, for inviting us to present to you today as part of your Friday seminar series. My name is John Olson, and I will be starting off this presentation defining rural, sharing some commonalities for our 3 states, and reviewing some useful health data sources. Excuse me. Let's hope that doesn't continue. My colleagues from New Hampshire and Maine will be presenting some of the particulars about their states and sharing rural health resources later in the presentation. We will also have time for questions and answers from participants. So, commonalities. What do Northern New England states have in common? Well, we talked about this in our introduction, our warm-ups this morning. Maple syrup, mud season, and tons of charm. I mean, look at that barn. So we've got charm like crazy here in New England. Each of us might argue about who is the better of the 3, but we all know that we're better than the other 47. So we have that going for us. We also share, excuse me, a scale of our settlements. We are a region of small towns and small cities. Our governance tends to be at the state and local town levels, not counties. Yet we are influenced by our neighbors, Boston, our larger neighbors, Boston and New York, as well as internationally from Quebec and New Brunswick. Along with New York State, we are all members of the Northern Border Commission that brings some additional federal funding to support a variety of activities for our states. Demographically, rural areas, including our 3 states, tend to be older and poorer than other US states and urban areas. There, of course, are variations. However, in 2018, America's Health Rankings by the United Health Foundation ranked Vermont number 4, New Hampshire number 6, and Maine number 16 among the healthiest states. Each of our states is primarily white, yet slowly and painfully sometimes diversifying. Finally, yes, we are rural, but not Wyoming rural. A comparison I often make is that Vermont may be the only state without a city over 50,000, or no McDonald's in our capital city, or some other unique measure, but Wyoming has fewer people than Vermont, spread over 10 times the geography. Now that is rural. But we do have, so how do we define rural here in Vermont and New England? Well, it depends. There are over 30 federal designations and definitions for rural, depending on the agency and department you are looking at. Some use a combination of the Office of Management and Budgets, metropolitan statistical area, micropolitan, non-urban, or rural or frontier. All of these are based on some combination of density, distance to services, commuting to metro areas, and other factors. In addition, each of the states across the country have their own definitions they use that may match one or more of those or be unique. In 2014, the New England Rural Health Association, formerly the Roundtable, put together their second Data for Action booklet and report. In the map to the right, you can see one of the pages that rank these 5 tiers into core and small metro areas, large rural, large towns and rural areas, small rural, and isolated in red. In other definitions, some of those might be considered frontier. We'll talk about some of those and how that plays out later in the presentation. If you are interested to find out if your particular location or service area is considered rural by HRSA and CMS, you can use the Am I Rural tool at the Rural Health Information Hub online. You can find out about current designations for health professional shortage areas, as well as other eligibility for grants and such. So what should rural health look like? Well, our national organization a year or two ago gathered a team of experts to examine this question about services and came up with the following report that they call a rural integrated service system, including clinical and non-clinical integrating and coordinating services. Many of you know that whether anyone says it out loud or not, healthcare in rural and non-rural areas must be concerned with the whole person for an entire lifetime, including high quality and affordable healthcare for all as the goal, covering a full range of services, social support, and public health activities. This clearly cannot be done by one organization, although often hospitals feel like they're being asked to do that. We all must work together to make this work for our rural neighbors. So what does the healthcare infrastructure look like in northern New England? The next few slides have a bit of a mishmash of maps provided by each of our offices, so there's not as much consistency. Thank you, Roundtable and Association, for providing at least one map that shows all the states in scale. But this is just a table and some location of most of the hospitals in our areas. If you would like to get a specific map for your state, please contact one of us following the session. But this shows that we have a range of hospital types and sizes and the locations sprinkled throughout. Except for northern Maine, we have a pretty good distribution in New Hampshire and Vermont, almost one hospital per county, compared to some other states out west where that's much more challenging to make that viable. Some other commonalities, but some differences. Many hospitals in Maine are parts of the larger systems, a few in New Hampshire and Vermont, but mostly in Vermont, the hospitals are independent, yet have relationships with either University of Vermont Medical Center or Dartmouth Hitchcock Medical Center. Again, get in touch with one of us if you'd like a clearer, usable map. Here again, another map that shows makes the point I was just saying about mapping, but also distribution. It also shows some of the ways that we can use GIS to plot locations and also drive times to hospitals and a variety of other needs. Check with us to see if we can make a map for you or if we already have it. Primary care is obviously another key component to healthcare in rural areas in northern New England. Safety net providers play critical roles in coordinating health services, especially in rural areas. By federal regulation, these practices must offer a sliding fee scale, accept all insurances and no insurance or uninsured patients, and generally employ mid-level clinicians like physician assistants and nurse practitioners. As an example, there's a mix of providers and many are independent. In Vermont, of our 220 or so primary care practices, half are independent solo or group practices, a quarter are federally qualified health centers, another quarter are hospital owned. We also have about 12 we each have Planned Parenthood health centers and some number of VA or Veterans Community-Based outpatient centers. In Vermont, we also have some free clinics that actually work with volunteer providers. Speaking of providers, healthcare workforce distribution. Each of our states collects, and our offices collects detailed data on a variety of healthcare professions to be used for workforce assessments, planning, mapping, and shortage designations. This may be high-level providers like psychiatrists and dentists and physicians, but also mid-level and other even entry-level providers. In Vermont, we collect data every 2 years during licensing for 40 plus health-related professions at the town level. And Vermont, or New Hampshire has a new law that requires that data reporting, and Nicole can tell you what they're doing in Maine. With that data, we can then map the providers and distribution by county, health service area, public health district, or as shown above, by rational service areas, which are used for shortage designations. RSAs are groups of towns that reflect care-seeking patterns of a population used for shortage designations and recruitment incentives. For all license types, we can provide a single profession map with just dentists or combine physicians and psychiatrists with other providers to show a true level of need in the area, like we see on the left there. I won't spend much time on this, but I will say, like, there's 3 or 4 slides here just to give you an idea. You can look at these and see the geographic patterns for them. For any of you, you know sort of the high needs areas in your states, but this is a nice view from HRSA for the patterns across the states. With this data, we then do HPSA shortage designations, including health professional shortage areas, which are available for primary care, dental, and mental health. They may be referencing geographic areas as outlined on the maps, or facilities shown as points for federally qualified health centers, rural health clinics, prisons, and minority health centers, and perhaps a few others. Scores, each site or area is scored on a scale of 0 to 25, or 26 for dental, as a ratio of a variety of factors, including a ratio of provider FTEs to population within the area. If need scores are high enough, the feds can fund loan repayment to providers working through the National Health Service Corps, State Loan Repayment Program, and some other programs. It's currently, I don't know what they're currently doing, but just because you have a designation doesn't mean that the feds have enough money to fund down to that score. So I think last I heard, they're funding to about a score of 14 to 25. So we'll see. In each of these maps, this one and it follows the darker areas, darker shades indicate a higher need, meaning there's more, very few people in some cases, but even fewer providers. This is the map for dental.
John, you went on mute.
Well, I hope you heard everything else about dental. That's good. Thank you for letting me know. So there's the dental health as well as mental health. Again, there may be some patterns, and most folks wouldn't be surprised that the North Country of Coos County in New Hampshire, the Northeast Kingdom in Vermont, and much of Northern Maine face shortage areas, challenges. But some of the strengths and challenges, as many of you know, rural communities are wonderful places to work, live, raise a family, and recreate. Sometimes just to drive through. Rural communities are often tightly knit places with long-standing relationships between organizations, families, and service providers. Healthcare systems, partners in social services are staffed by dedicated folks who know and love their communities, often over decades. Family members and relatives, there are some complications, as family members and relatives and friends from high school may serve on boards of your hospital or your clinic and run the bank, or have kids on sports teams. And likewise, many healthcare providers and leaders wear many hats, especially in small organizations and communities. That is part of the richness and the challenge of rural living. But sustainability is an increasing challenge. Increasing patient needs, evolving regulatory demands, fragile operating margins make healthcare stressful, whether you're the boss or an employee. In addition, the planned transition to value from fee-for-service to value is an unknown path facing providers in each of our states. And surprises like disasters, natural and otherwise, and pandemics test the mettle of everyone as well as our endurance. The ongoing pandemic response is taking a major toll on providers, both in public health and in clinical settings, and forcing us to embrace virtual care, virtual access to care through telehealth, which has been a slow uptake for decades, or about a decade. So let's learn a little bit more about the populations in New England. There are two tools that I want to talk about today, not too much in depth, but there's a few slides each that help us understand both the social context as well as the health outcomes for residents of New England. First is the Social Vulnerability Index developed by CDC, sometimes called the SVI, helps leaders and communities understand their community's vulnerability to disaster and disease outbreaks. We're getting some practice with that currently. These two maps show the US counties and their SVI flags grouped by quartile. Darker shades, again, show more vulnerability across 15 different factors in 3 themes that are listed here. Socioeconomic theme, not surprising, includes factors of income, poverty, educational attainment, unemployment rates, and health insurance. Demographic theme touches on children, percent under 18 years old, elderly, folks with disabilities, a percentage of folks with disabilities, single parenthood, minority status, and limited English. Housing and transportation covers, excuse me, percent of folks living in large apartment buildings, and as well as mobile homes, crowded spaces, have no vehicle, or group quarters. Each of these creating some challenge to responses in emergencies, but also for accessing healthcare. While some New England counties show significant vulnerabilities on the map on the right, especially the more rural parts, the US map is striking in the distribution of social vulnerability factors. The national map highlights the significant vulnerabilities facing counties and states that with larger populations of Black, Indigenous, and other people of color, so-called BIPOC communities, period. So with long-standing historic disadvantages. That's the big picture. Let's take a look at some of this on a smaller scale in parts of New England, and also how to use your tool. As we zoom in, use the SVI online tool to zoom into parts of New England, we can see variation between census tracts that we miss at the larger county level maps. Now, these census tracts represent hundreds or thousands of people, not millions as on the national map. However, excuse me, we do notice significant variations between towns or between neighborhoods within the same town or cities. Identified on this map are the city, Newport City and Derby, Vermont on the upper left, Lyndonville and Linden, Vermont, East and West Berlin, New Hampshire, and the areas are near Rumford, Dixfield, and Wilton, Maine. You can see the shades of color indicate how well or challenged and vulnerable some communities are versus others. Taking a look at the SVI tools available for Vermont and New Hampshire, and perhaps Nicole can talk about whether she has this in Maine, we can get a statewide view showing the numbers of SVI flags by census tract by individual factor of the 15, the 3 themes, or a high-level composite of all shown above. In both maps, the tracts are shaded into 6 groups of flag counts. SVI also allows us to click on the census tract to get more specific information about that community and each factor. Interestingly, on the Vermont composite map, many of the most vulnerable census tracts are located in towns or cities with hospitals. So access to care and vulnerability are not necessarily equated. This would likely not be a surprise to any healthcare leader working in those communities, but it does provide data and insight to better understand the communities and to assist in planning and problem solving. The second database I want to introduce you to, and thank you, Alisa, for introducing it to me, is also from CDC called Places, put together as a collaboration with the Robert Wood Johnson Foundation and CDC Foundation. This data set and mapping tool focuses on health-related outcomes at the census tract level as well. Not surprisingly, these maps show similar hotspots for health outcomes as we saw in the social vulnerability factors. Here we see physical health distress reports, as well as percentage of folks reporting frequent mental health distress, I think from a few years ago. Likewise, dialing into that same region I showed you earlier, you can see some of the detail of at the census tract level and also town boundaries highlighted in red, in this case for loss of all teeth for folks over 65. So you can see the percentage there, and you can see the variation in the various communities. Okay, so variations between our states. Well, think about your neighbors and the news. We are not, while we are all Yankees, we are not necessarily all Yankee fans. I don't even pay attention to baseball, but that's my own flaw. But we do have varying approaches to government as well as structures, and our politics are sometimes similar and sometimes very unique. We have generally adopted healthcare innovations across the region. New England tends to lead the nation, yet we are taking our individual approaches kind of like pilot programs. So that's been interesting to watch for me over the last 10 years. If you're a provider, you're probably less interested in all the change that's been coming at you for 10 and 20 years. Our economies have some similarities, but it's not all maple sugar and ski areas, although there is some of that. In Vermont, our brave little state, we have Vermont, as any of you know, is a highly regulated healthcare environment with fairly well-distributed healthcare system by and large. Our small size, progressive nature have led us to take on healthcare reform, innovation, and health equity across the state. And we have, with only 600,000 people, it's easy to know your legislator and see your colleagues and coworkers at the local grocery stores and farmer markets or on a hiking trail. Speaking a little bit about healthcare reform, some highlights include the establishment of the Blueprint for Health in the early 2000s, taking a look at chronic condition management, institution of community health teams in each hospital area with community partners, the hub and spoke opioid treatment system with residential centers and outpatient management. And more recently, state government has taken a health in all policies approach across all the agencies, and hospitals and other communities have adapted to the Accountable Communities for Health model. The Green Mountain Care Board is our independent regulatory regulators for health care and insurers, or particularly hospital budgets, insurance rate setting. The state has, and all the healthcare folks have adopted the all-payer model from CMS in a single statewide ACO environment with almost all hospitals, FQHCs, home health, and other providers enrolling in it. Participating. In a year or so ago, the Green Mountain Care Board convened at the legislator's request or command, a Rural Health Services Task Force, and we published our report in January of 2020 that mapped all of the facilities of various types, including pharmacies and optometrists, and as well as the workforce issues and some suggestions for moving forward. We just started this last week, our 4th or 5th iteration of workforce advisory and planning. So that's going to be keeping on going to take our next steps. We also have the Department of Health also publishes the workforce census reports biannually with the details and summary or even data briefs for for some professions. MAT referral is available from most emergency departments now to a referral within 2 or 3 days to a local provider for folks to avoid any waiting list for services. And relating to health equity, each state health department is working to assess, understand, and address these social determinants of health, historic injustice, social vulnerabilities, and the related health outcomes. In recent years, our understanding and approach to health disparities and health equity has been evolving. Some of you have been a part of this process. In 2017, we made the choice to incorporate health equity into our state health assessment reports, as well as the state health improvement plan. These plans guide the health priorities of the Vermont Department of Health and partners across the state. We aim to focus on equity throughout the process of developing these documents, including in the questions we ask partners and individuals who participate in the process and the data we examine. And then finally, I will turn this over to my colleagues and greet all of you from the west coast of New England with a sunset. That was yesterday, not so much today. So next up we have Alisa from New Hampshire. And she will tell me to click as I need to.
Thank you, John. Just as a disclaimer, I am not from New Hampshire. I've only lived there since 1997. And as I've been told many times, that means I am not from there. And it'll probably take a few generations before my family is considered to be from there. But I have been there since 1997. I chose New Hampshire literally from any place I could live. For the first time as a military brat, I got to pick where I lived. I picked New Hampshire, and I've been in love with it ever since. So for my part, I decided we're all 3 totally different personalities, I think, that go along with being 3 totally different states. So for my portion, I decided that I would like to tell you stories about rural New Hampshire and what's happening in there, because what I really would like you to leave today with is that rural is an innovator, and a lot of people who live in rural communities are innovative and have been for generations. And I think that working in rural health has given me the ability to really experience that both with projects that we have been the lead on, but also projects that we have come in and tried to document or help expand or sustain. The other thing, the reason I'm going to tell you stories is that's one of the things that I've also learned about rural is that they are great storytellers. And there is always so much more richness to their story than just a story. And I've learned a tremendous amount about rural culture just listening to folks' stories. And then really rural as experts. I'm a community and social psychologist, so I am trained. And I firmly believe that you go to the experts and the experts know the most about their own community. So gathering stories for you today, I went to the experts and I called up a lot of my friends who do rural health in New Hampshire, and I asked them what they wanted me to tell you. And so these stories really are a reflection of the stories that they asked me to share with you. Click. So I told one of our CEOs of one of our northern federally qualified health centers about you guys as a group, and that I was doing this seminar with my colleagues. And one of them said, oh, please tell them about research. So he has been involved in a number of research projects and just wanted to share what he thought has been most successful. And that is really making sure that it is relational versus transactional. So you are creating a relationship and you're really looking for a long-term, not necessarily project, but involvement to really understand what's happening in a community. And really you can come at this with the co-creation of research. So he has done some projects with universities where there's been really that aspect from the get-go, where you develop the project together instead of somebody sort of knocking on his door or ringing him up and asking to drop a project into his environment. And that he really has found that the most attractive to people who are doing daily healthcare in order to make space for research to happen really is something that creates practical value for patients. And then he shared a couple of things that they are working on that do just that. And that really to stress that to balance rigor and pragmatism with fidelity. So I promised him I would share that with you. John, next. Okay, so one of the programs that I wanted to share with you highlights the importance of community health workers. And the community health worker program is very, very new in New Hampshire, and we've been watching it all over the country. And in fact, all of the stories I'm going to share with you today are about innovative ways to increase access and reach patients that were all rigorously studied elsewhere. So all of the things that we implement and we support that bare minimum are a best practice, and at best are evidence-based, or we actually, from the State Office of Rural Health, will fund projects to develop and collect that evidence. So one of those is the Community Health Worker Program, and the North Country Health Consortium, which is the oldest rural health network in New Hampshire, has this program. And it is focused on people who are 65 years or older with a chronic disease who were referred by a medical or social service provider. And they provide chronic disease self-management, health information, and assist with managing provider instructions and medications. And it connects them to services and supports that can help with paying for medication, medical bills, food, transportation, and housing. And so what the community health workers do is they are given the referral from a provider, and they go to the patient's home and they build a relationship based on trust so that they can try and figure out what the barriers are to this patient achieving wellness. So theoretically, they've been told what to do and how to manage their chronic disease, but they're still having difficulty doing that. So a community health worker can really try and identify the social determinants of health that are barriers to chronic disease self-management. And so one of the stories is about a patient named Janet. And before Janet had a community health worker enter her home, she was not managing her diabetes and she didn't have a handle on her medication routine. She told the community health worker that she didn't understand why the pharmacy kept filling her medications because she had plenty. The community health worker discovered that Janet's plentiful bag of medications was actually a duffel bag full of medication. Together, they learned how Janet could use pill boxes and what routine would work in her life. The community health worker provided her with education and encouragement, communicating their progress directly to her provider in primary care. In the beginning, Janet needed step-by-step instructions on how to fill her pill box. But within a few weeks, she would have her pill boxes ready and filled by the time the community health worker arrived to review them. Not only did her A1C and memory improve, but she also gained a ton of confidence. So that's the kind of work that community health workers can do. Next slide, please. This program is also from the North Country Health Consortium, and it's called WARM, and it's the Wellness and Recovery Model, and it's focused on SUD treatment. And so this is a story I can share with you about Amanda. Amanda had a rough upbringing, raised in a home where she experienced physical and emotional trauma at the hands of her father. At the age of 19, she began experiencing a series of panic attacks and was diagnosed with an anxiety disorder and prescribed medication. At 21 years of age, she injured her back. This injury led to the physician visits, an MRI, and ultimately a diagnosis of degenerative disc disease and a prescription for oxycodone. Over time, Amanda became dependent on oxycodone and her life began to spiral out of control. She was losing everything she had been working so hard to maintain. She became homeless and could no longer care for her son on a full-time basis. Over the next few years, Amanda would continue to use, and at the age of 27, her life would change again. Amanda had become pregnant and given birth to a beautiful baby girl. Amanda's baby girl had been born exposed to substances. 6 weeks after the birth of her daughter, Amanda experienced another medical emergency. She had septic shock, and this led to a collapsed lung. After spending a great deal of time in the hospital, Amanda decided that it was time to make a change. She began looking for substance use disorder treatment, but there were very few options available in the North Country, and she was placed on some lengthy waiting lists. While waiting for an intake to access treatment, Amanda continued to use and was charged with driving under the influence. This charge ultimately led to DCYF removing her daughter from her custody, and Amanda began to seek other treatment options. She began to search for intensive outpatient programs and medication-assisted treatment as a pathway of recovery. Amanda was able to access programs at Dartmouth-Hitchcock Medical Center and attended the program 4 days a week for 3 weeks. And that's quite the commute from the North Country. Amanda was informed by her case manager that her situation was too complex and beyond their level of care, and they could no longer continue to treat her. Amanda was able to access another DHMC program in the North Country at Indian Stream Health Center in Colebrook. She was able to transfer services and remain close to home. She continued to maintain her recovery and began to run a support group for others struggling with SUD. Amanda became independent, secured her own vehicle and stable housing, developed healthy boundaries, and reunified with her children and her father. Today, Amanda is employed as a certified recovery support worker and the supervisor of reunification and recovery services at the Family Resource Center in Gorham, New Hampshire. And on February 21st of 2021, Amanda celebrated 5 years in recovery. Next. So this program is that I'm going to describe to you, it's less of a story and really a description of a new workforce model to increase access to oral health services. So of course, in an ideal world, there would be plenty of dentists, and those dentists would have a public health bent, and they would be taking all patients regardless of ability to pay, but that is not how it works. So in New Hampshire, we have something called a certified public health dentist, and it is additional curriculum that you are then actually certified for through the licensing board. So in 2012, the New Hampshire legislature passed this legislation creating a new dental provider type. This certified public health dental hygienist works under public health supervision, and they can provide an expanded scope of dental hygienist services, including oral assessments, prophylaxis, topical fluoride application, including silver diamine fluoride placement, fluoride releasing dental sealants, and interim therapeutic restorative or temporary fillings, and the taking of x-rays. So this means they have all of those sort of preventive and assessment skills that they can be used in the field. So 2 of these programs are integrating dental services into primary care. And as part of the evaluation of the program, they had people interviewed. So interviewees from these programs reported that the programs have helped raise awareness of the importance of oral health among primary care providers. They shared that prior to the presence of the certified public health dental hygienist, primary care providers faced challenges in addressing the oral health needs of patients who presented with oral health concerns at their medical appointments. Now, primary care providers are referring patients directly to these certified public health dental hygienists. Primary care providers are key to the success of public health dentistry services, as they are often the bridge from patients to dental professionals. Thus, the New Hampshire sites involved in this grant have spent time educating and bringing primary care providers and medical assistants on board. Key interviewees shared is ensuring providers that having dental services on site does not require them to do more about oral health, just identify and refer. So we're not asking primary care providers to add yet another thing onto their tool belt, but just really to understand what these models can do and then how to connect patients with them. So demonstrating how valuable the program is and how it can support primary care is really critical to getting primary care's buy-in. So the New Hampshire Certified Public Health Dental Hygienists have found that primary care providers have welcomed their presence because, as one person pointed out, many providers were previously seeing patients with oral health needs, but they did not have the tools to help them. Primary care providers have limited time with patients and often have other pressing health issues to discuss, and finding even a little time for oral health can be challenging. So those are some models with that. And then next slide. And this is my last one, and you can really read it, but I wanted to provide a couple of examples that were telehealth specific. And these have been collected during the pandemic, where there has been a tremendous amount of both reason and support for some of these safety net providers to pivot to telehealth. And these are all examples of ways that patients who already have established relationships have been able to overcome barriers, both those that are, unique to the pandemic, but also those that are just part of everyday life that would take a tremendous amount of coordination. And this way people can just access healthcare in the way that works for them. So on one side, you have someone who talks about, the fact that a lot of patients have social anxiety disorder. It's very difficult for them to even prepare to leave the house to attend an appointment. Those folks who are with disabilities, it's difficult to get transportation that's appropriate and access places. And then there are a lot of places where people require family members to help them out. And so then somebody's taking time off their job to drive what can sometimes be hours round trip. including the weight. In order to do that, there's a cost involved with that. There's a social cost involved with that as well. And then childcare and things like that. And then the example on the right is really about any of us who have children definitely know what it's like to try and juggle children. So this is about a mom who really needed this care for her postpartum depression and was able to do this while juggling her children because she was able to do it from her home. That's it, John.
Great, thanks. And next we'll hear from Nicole in Maine.
Hello, everyone. I remembered to take myself off mute this time. So I'm Nicole Breton. I am the State Director for the Office of Rural Health, Primary Care, and Oral Health. I am the youngest of the SOAR directors, I think, in New England. I've been with the program for actually next April 6th will be 6 years. So I have wonderful mentors in my New England states, working with John and Alisa, and also with Kathleen in Massachusetts also. So as we're all a little different, so I'm basically going to just go over some of our demographics, but John asked me to talk a little bit about what's really unique to Maine is our island communities and our delivery of care throughout our getting care out to our islands. And so I'll talk a little bit about that also, but some of the data, as you may not know, is that we are the oldest state. Our median age is 45. In our rural areas, our population is dropping significantly. We every year experience school closures because there is just not enough populations or consolidation. We are the least densely populated state east of the Mississippi River. We average about 43.3 people per square mile. Some of our vulnerable populations, we have a high portion of veterans living in our state, mostly rural. Only Virginia and Wyoming have more veterans living in, have a more population. Basically, in our rural areas, we have a higher population of working in agricultural, forestry, fishing, hunting industry in New England. So, you know, our lobster, we are known for our blueberries, broccoli, potatoes. We also harvest reefs from the reefs across America that travel every year to Arlington. So also takes into consideration occupational health hazards. So, you know, it is hard if you have an injury working in the woods of Maine, you know, so those are some of the challenges. We also have the highest rate of food insecurity in New England, something that our state is aware of and are working on to address this issue. Next. So just some of our health outcomes is basically, we have, you know, our heart disease and cancer are our leading causes of death. We didn't put this slide in there, but Maine is also seeing an increase of overdose deaths. Last year, we had our highest rate ever, which is now reporting the government has a task force to address this issue, and we'll be doing monthly reports out on it, something that we've been working on. COVID has not helped this. It has made things worse for our population, and especially in the rural areas. Maine also has had, in the past 7 years, increase in mortality deaths, especially in our rural areas. It changes depending on the county, but Piscataquis County has the highest rate of infant mortality deaths, which is in our most northern region, and has the highest unorganized territory. One thing we do know is that our rural hospitals, their OB/GYN services and maternity are closing at a rapid rate. which is a health disparity for a pregnant mom trying to seek care. And what we know in Washington County, our Calais Hospital stopped delivering babies 7 years ago. A mother on a good day to seek maternal child help would have to travel a good hour and a half, and that's on a good day to seek care. So some of these are some of our challenges. Next slide. So through our community shared needs health assessment, all the counties come together. Maine has a strong local and community and coalitions, but these were identified as some of the top priorities that these communities and counties came together to work on. So access to care is always an issue. Mental health services, substance abuse services, safe housing in food security is another issue. Also, transportation is our biggest barrier. And then older adults and healthy aging. So really a big push to have our older adults stay in place. The other factor is that our Maine has experienced a high number of nursing home and assisted living facilities closing. And so these individuals usually are relocated sometimes 2 to 3 hours away from their loved ones, which is significantly a challenge and something that, you know, the state is looking at and working on. So next slide. So this is our healthcare safety net. We have 16 critical access hospitals as in the map earlier. I will share with you in the last 2 years, 2 of our critical access hospitals entered into bankruptcy. I will be pleased to share through our office, we were able to get one of our hospitals, Penobscot Valley Hospital, into a vulnerable hospital assistance program through HRSA. And in December this year, they are now emerging out of bankruptcy. So it's a positive thing. And they are gaining sustainability. The other hospital, Calais Hospital, which is the very tip of Maine on the coast, it borders Canada, has been in bankruptcy. Our office has been heavily involved in this bankruptcy, and I'm pleased to announce this week to share publicly that their hospital within the Washington County, Down East Community Hospital, will be buying Calais Hospital. So this is a little bit of a different, it's not a healthcare system, they're an independent hospital that will be buying another critical access hospital. So we will be able to sustain care in that region. We also have 190 health centers, federally qualified centers, and lookalikes. We have a few of them that are on our island communities, 5 tribal healthcare facilities. We have 9 safety net dental clinics and our school oral health program. This is a long-standing program within the Maine CDC. This is where I started my career in public health. And we service over 188 rural schools throughout the state. And we utilize public health field hygienists to go into the schools and do basic screenings, fluoride varnish, and dental sealants, and care coordination and when we find children that are in need of emergency or urgent care. So this has been a little bit different this year for COVID, but we have implemented a little bit of our own teledentistry. So teachers taking pictures of students and then sending them to the public health field hygienist, and then them trying to assess that through the image and talking to the parent and then trying to get them into care. I will also share with you that Maine last week just approved their first dental therapist in the state of Maine. So this was 7 years plus of getting a dental therapist in the state. We are working closely with Vermont Community College for their dental therapy program is to send Maine students there to get their training and hopefully come back to Maine and be dental therapists so we can spread that in more rural areas of the state. Next slide. This is just a picture, and I think earlier, of just where we're located, our critical access hospitals and our small rural hospital improvement. These are mostly PPS hospitals that are part of our SHIP program, navigated throughout the state. And then the next slide just shows where all of our safety net is located. So workforce, contrary to many people's beliefs, we are ranked 3rd in the country for primary care providers. We could always use more, but we do better than some of our other states. We rank 4th in the country for mental health care providers. We always need more psychiatrists. That's been our biggest challenge is recruitment and retention of psychiatrists. Maine rates 27th in the country for a dentist. I always joke that we have more moose in Maine than we have dentists. Through the UNE dental program, they have a track for the 3rd and 4th year students that they are doing their residencies in rural areas, and in hopes that it will attract them to 1, stay in Maine, and 2, relocate to a more rural area of the state. Our other workforce is our J1 Conrad 30 program. We have been very successful over the last several years, filling our slots within the first hour and minutes of the day. This helps. We also have a stronger retention of our J1 Conrads. We have over, I think it was about 57% of them do stay in Maine after they finish. So that is really good. And we have a Maine's Physicians Residency Program. We have a higher retention rate of the providers staying and working in Maine. They may choose to work in the southern part of the state, but at least they're staying in Maine and working. Next slide. So island life, and this is what John talked. And so if you've never been to the Maine Islands, I encourage you to go. Usually I end up going on my site visits on days like this, where it's rainy or in the middle of February and I'm caught in a horrific sea storm. So we have over 4,000 islands that can be found along Maine's coast. 15 of those islands have year-round populations. Most of those islands do not allow vehicles. The main transportation is through golf carts and bicycles. Peaks Island does allow people to bring their cars on the island, but most of the time the cars are only allowed for the residents. So island healthcare, this is my story because I know I don't have a lot of time. This is the Sunbeam. This is housed in, on the Penobscot area, in the Penobscot Bay in Bar Harbor, Maine. This is a delivery healthcare system to rural islands. It travels out to about 15 islands bi-weekly. They have state-of-the-art telemedicine, teletechnology way before COVID hit. They have a nurse that goes out and provides care to the island. Basically, the islanders will come and get their care on the ship, but if an islander is unable to get to the ship to provide care, they will then travel to their home. And usually they also do truck visits. That means that if they're out and about in the community, they usually are stopped by one of the locals and asked to look at something. I live in a rural area in the northern woods, and this is very common. If they know you're a healthcare professional, they will seek you out before they will go to the doctor. Through this, they do all telemedicine visits, mostly around primary care, but also substance abuse and mental health services. And they bill for those services. The other care that they provide is free of charge to all of the islanders. They are a nonprofit and they mostly run on grants, endowments, and donations. And you can go to the next slide. So some of our strengths in Maine is we have a strong safety net with all of our critical access hospitals. Years ago, we started working with them in a network development. So we work, we meet with them, the CEOs, the CFOs, the quality improvement folks, and the nurse managers and nurse executives quarterly. We provide, we pool our grant funds together to provide them with expert subject matter consultants and technical assistants. Our hospitals share their data unblinded with us, and that's just with quality improvement, HCAHPS. Also some of their financials, which is unheard of with most hospitals. They came together and we work in unison closely with them in the state office and also the Maine Hospital Association. You can go to the next slide. Workforce is, and we have some maps also. So if anything that you need from us, you can reach out to us. But we just conducted an analysis. Basically, primary care visit was under 30 minutes for the state, which is a good thing. We work closely with our Maine area health education network and have shared projects with them over the years. And we continue our office to support education and training programs to grow. And then just basically overseeing one of our primary goals, especially this last year with COVID, and we've seen an unbelievable interest in rural people wanting to practice in rural Maine. So workforce recruitment and retention is now my part-time job. So I've been working on that a lot, and it's actually been fun. I get to talk to these wonderful providers and look where they want to possibly relocate. And I love getting thank you notes and cards from hospitals and federally qualified health centers when they are able to secure a position. You can go to the next slide. And I think, John, you're going to go here.
Yeah. Thanks, Nicole and Alisa. And I apologize, everyone, for taking a lot of time on that draw your data stuff beforehand. We're not going to cover in any depth because of the time. We've got about 2 minutes left. We're not going to cover the resources, but they are on here. And Jennifer has offered to make those into a PDF that with active links that can be shared. I apologize, Anne-Marie. We're just going to have to, everyone's going to have to trust us that Anne-Marie is awesome, and so is the New England Rural Health Association. But there are a number of resources that might be useful for you folks if you don't know about them already. So watch for those. Do we have any particular questions that people want to ask in a moment or two?
So no questions. Oh, one question here from Heidi. Heidi, you're welcome to unmute yourself and ask.
Yeah, sorry about that. So I've been a public health hygienist in Vermont before, and I was interested in New Hampshire's public health hygiene. It sounded like they have a little bit more functions than we're allowed in Vermont, but not really. We're allowed to do SDF and varnish. Anyway, so I found it very difficult to find dentists to work with when I was working with the underinsured and uninsured. And so I wanted to know how you address the need for dental work outside of the scope of practice for the public health hygienist, how you recruited dentists to participate at a rate that was affordable, and especially oral surgeons, because extractions, unfortunately, tend to be the major need.
So the project that I read you a little bit from was focused on federally qualified health centers. So they are places where either there was a clinic or that they have federally qualified health centers are required to integrate oral health and dental health. So they do that in a number of different ways. And so some of the places were fully integrated and some of them just had relationships. So that's really where the project was focused. So because they see everyone regardless of ability to pay, they either provide that dental treatment there or they have a relationship with a dental practice that will do that.
Okay,
now,
that makes sense.
We certainly have many parts of New Hampshire where that is not the case. And we are actually working on right now a workforce project that would be a pilot project for private practice dentists to encourage them to take Medicaid or take more Medicaid. So they would not have to be like our traditional loan repayment sites. They would just need to do Medicaid. So we've been working on the data and with our oral health director of Medicaid to come up with that pilot that we hope to launch soon. Now, that is not going to solve all of the issues. There's a Medicaid reimbursement issue. There are a number of different issues, but really sort of looking at all of the different points in the system we can leverage to try and create more capacity.
Yeah, and that would be a good expansion for sure.
And we have, we have the dental school in Maine that has a mission, it's public health, and it has a mission to serve New England. So what we found is since they've been up and running and graduating students, those dentists, those fresh, newly minted dentists, they want to work with the type of patients that you're describing. And so there's definitely more opportunity to connect with those students and those new dentists as that supply increases.
Great. Thank you.
Great. Thank you so much. We're just past the hour. Thank you so much to all of our speakers. Jennifer has put a note in the chat box that will contain the link to the NNECTR site where you can find the slides if you are so inclined.
Just give me a few hours to get the link and it'll be up.
Thank you folks for attending today. Hopefully it wasn't too repetitive. I love the stories from New Hampshire and Maine. We look forward to working with each of you. Please reach out to us directly for any questions you may have. We're here to help.
Thank you very much. And what you have done, I mean, has been incredibly awesome and necessary, particularly during the past 2 years. It is appreciated very much so. Thank you.
You're welcome. Thank you, Dr. Stein. Thank you, everyone. Take good care.
Bye-bye.
Very much.
Take care.